Hello everyone, welcome back. Today we are going to cover regarding acute hematogenous osteomyelitis in children, AHO Part 1. We are going to start off with an introduction, pathogenesis and pathophysiology of acute hematogenous osteomyelitis, microbiology of acute hematogenous osteomyelitis, microorganism in specific risk factors group, clinical presentation of acute hematogenous osteomyelitis, the differential diagnosis, the inflammatory markers, that means the laboratory investigation, and radiological investigation to diagnose acute hematogenous osteomyelitis. As an introduction, osteomyelitis is defined as an infection of the bone and bone marrow. It is associated with inflammation and bone destruction. Osteomyelitis can be classified into A. Acute, whereby the duration of symptom is less than 2 weeks. B. Subacute, the duration of symptom 2 weeks to 3 months. C. Chronic osteomyelitis, a long-standing infection that evolves over months to years. Osteomyelitis can be a result from A. Direct inoculation from a penetrating trauma. B. Spread from a contiguous site of infection. C. The most common cause is hematogenous inoculation of the bone during an episode of bacteremia. Pathogenesis of acute hematogenous osteomyelitis. It is common in children less than 5 years of age. It affects the metaphysis because the rich but slow flow of the growing bone. The microorganism enter the bone via the nutrient artery and are lodged in the metaphyseal capillary loops where they begin to proliferate, resulting in the spread of inflammation. This picture illustrates the dilated turning point in the metaphyseal capillary loops. It has sluggish flow that allows the bacteria to stay there and proliferate. Remember, this is an important exam answer. In neonates and children less than 18 months, the metaphyseal vessel loop and epiphyseal vessels are connected via transphyseal vessel traversing across the growth plate. So the spread of metaphyseal infection to the epiphysis and joints can occur via transphyseal vessels. This figure illustrates the difference in blood supply in the bone. Starting from infant that less 18 months of age who has transphyseal vessel, then transition to adult after the growth plate is no longer present. What is the pathogenesis of acute hematogenous osteomyelitis? In older children, the vascular connection between the metaphysis and epiphysis are obliterated, and the two blood systems, the metaphyseal loops and epiphyseal vessels, are separated from each other. Osteomyelitis of the proximal humerus or femur may be associated with septic arthritis if the involved metaphysis is intracapsular. Boys are twice as likely to be affected than girls, and children less than 5 years old account for more than 50% of cases of acute hematogenous osteomyelitis. This picture illustrates the pathogenesis of acute hematogenous osteomyelitis. After Staphylococcus aureus is being lodged in the sluggish blood vessels, they form a microabscess within the loop of metaphysis. This will lead to necrosis of the cortical bone that results from the cut-off of the blood supply. The pus fills the bone cavity, becoming abscessed and trapped below the periosteum, causing the periosteum to be elevated. Bacterial etiology of osteomyelitis varies with age. The commonest is Staphylococcus aureus, 80% of the culture-positive cases. This is followed by Group A Streptococcus. In neonates, Staphylococcus aureus, Group B Streptococcus, and gram-negative enteric bacilli are the usual pathogens. Neisseria gonorrhea found in neonates and sexually active adolescents. Kingiele, sorry if mispronounced, is increasing as common etiology in some countries. Haemophilus influenza type B (HIB) is rare now due to vaccination program that is started in 1990s. Children who are not immunized, who are incompletely immunized against Streptococcus pneumoniae, have higher risk of developing invasive disease. Example, bacteremia, meningitis, pneumonia, and bone and joint infection. This figure illustrates microorganism causing osteomyelitis in a patient with a specific risk factor. In sickle cell disease patient, the common organism is Staphylococcus aureus, Salmonella species, Streptococcus pneumoniae. For trauma patient, the commonest organism is polymicrobial, gram-negative, gram-positive, and anaerobic bacteria. In patient who has chronic granulomatous disease, the organism is Serratia species, Nocardia species, Burkholderia, Cepacia, Aspergillus species. In animal or human bites, Pasteurella motocida, Echinella corrodens is the common organism. For puncture wound, the commonest organism is Staphylococcus aureus, Pseudomonas aeruginosa. In clinical presentation, the most common clinical features of pediatric acute hematogenous osteomyelitis reported in 2012 systemic reviews are pain around 81%, localized signs and symptoms around 70%, fever around 62%, reduced range of movement around 50%, reduced weight bearing around 49%. Other manifestations include fever of unknown origin and back pain with vertebral osteomyelitis. Systemic symptoms and signs such as high fever, tachycardia, and painful limb commonly in children with methicillin-resistant Staph aureus osteomyelitis than in those with MSSA methicillin-sensitive Staph aureus osteomyelitis. Children with Kingiele infection has benign presentation and cause with less than 15% febrile during admission and 39% with normal C-reactive protein level. Differential diagnosis of acute hematogenous osteomyelitis. 1. Infection 2. Example, septic arthritis, cellulitis. Trauma, need to rule out fracture. Malignancy, example, osteoblastoma, acute lymphoblastic leukemia. Ewing sarcoma, osteosarcoma. Bone infarction in children with sickle cell disease or other hemoglobinopathies. Metabolic disease, example, Gaucher's disease. And chronic recurrent multifocal osteomyelitis. The diagnosis of acute hematogenous osteomyelitis is established from a combination of history, physical examination, laboratory tests, imaging, and isolation of microorganisms from the bone, the joint, or blood. The non-specific markers of inflammation, the C-reactive protein CRP and ESR, erythrocyte sedimentation rate, are commonly used. CRP has a half-life of 19 hours. Mean time to normalization of CRP is around 7 to 10 days compared with ESR. That is 2 to 3 weeks or more. Because the CRP decreases more rapidly than the ESR, CRP is a preferred test to monitor the cause and resolution of illness. For culture, prior to admission or administration of antibiotics, obtaining a blood culture and bone biopsy or joint fluid samples is crucial. Bone or joint sample cultures have higher diagnostic yield, around 40 to 50% positive compared to blood cultures, around 10 to 40%. An organism is recovered from or in any source is approximately 40 to 50% of cases of acute hematogenous osteomyelitis. Isolation of Kingia on standard culture media is difficult. The detection of this organism is enhanced by direct inoculation of bony exudates or infected joint fluids into blood culture bottles, but the detection rate is around 33%. This picture illustrates a blood culture vials. Imaging techniques. Lytic lesions and periosteal new bone formation may be evident on plain radiograph 2 to 3 weeks after the onset of symptom. The earliest changes that you can see in the X-ray sometimes around day 5 to day 7 of symptom. A radiograph can exclude a fracture and malignancy, example Ewing sarcoma. Ultrasound is sensitive in detecting joint effusion. Technetium radionuclide or a three-phase technetium radionuclide bone scanning or bone scintigraphy is a sensitive test and useful to locate ill-defined sites of long bone infection or to detect multifocal disease or in cases where MRI is not feasible due to indwelling devices or braces. This radiograph of right knee region shows an osteolytic lesion at the proximal one-third of right tibia that might suggest osteomyelitis. Whatever it is, the imaging modality of choice is MRI. It has higher sensitivity, around 97 to 100%, and specificity, around 92% compared to radiograph or bone scintigraphy. Early changes in osteomyelitis can be detected on MRI within 2 to 5 days of onset of disease. MRI can also detect extraosseous manifestation or complication of acute hematogenous osteomyelitis such as myositis, joint effusion, or subperiosteal abscess, and help in the planning of the surgical approach. The limitation of MRI are the cost, the availability, the long duration of scan time, and need for sedation or anesthesia, especially in children. This MRI shows periosteal enhancement, marrow edema, and soft tissue enhancement that would suggest acute hematogenous osteomyelitis. Yay! We have reached to the end of the video. In part 2 of acute hematogenous osteomyelitis, it is mostly covering the management of acute hematogenous osteomyelitis. So see you in the next one. Take care and bye.